Associates down St. Joe, I think, probably. Well, you probably cover all the hospitals, right? Pretty much, okay? So he's here to speak to us about erectile dysfunction as a side effect of cancer treatment, prostate cancer treatment. And we'll cover some of the causes and what you can do about it, just the effects that it has on your quality of life along the way. And I'm sure we've talked about that some, and I'm sure the ladies talked about that tonight too. So, Dr. Willis, come on up.
All right. Well, thank you for having me. I'm pretty new to the area, so I'm from Richmond, Virginia, so I'm an East Coaster. Yeah, well, my wife's from Portland, so that kind of brought us over here. I did my residency at the University of Florida. I've been in practice here for about 3 years, but I did a fellowship in urologic oncology at MD Anderson Cancer Center in Houston. And it really kind of changed my perspective on cancer. And I understand that everybody here in some fashion is a prostate cancer survivor. And if there's any questions or comments, really this is for you guys. So if you have any questions, feel free to interject. Just my little spiel about prostate cancer before we start. Prostate cancer is really tough, and I kind of tell people you don't really know who your friends are sometimes, because everybody looks at prostate cancer through their own lens. So the patients look at it through their own lenses of trying to balance what I call cancer outcomes versus functional outcomes. And some patients, all they care about is cancer outcomes. Some patients, all they care about is functional outcomes, meaning sexual function and urinary function. And how do you balance that? And then you come to the providers, and then we all look at it through the lens of our own treatment modality. So we all have a little bit of bias in that part. Doing a fellowship in cancer, I like to think that we study the cancer, and then the treatment options are part of our armamentarium. And so that's something that I feel like my cancer fellowship brought a little bit differently, but I'm a robotic surgeon, so I'm a little bit biased there. And I would have been loved to have been here for the first hour, and I'm sorry that's a little late. I'm actually on call that I can have surgery after we're done. There's no rush, but we'll take care of that. So the purpose of our discussion, I don't know if I need the microphone or not, but the purpose of our discussion is to discuss erectile dysfunction. And just so I kind of know, erectile dysfunction comes in a variety of ways of prostate cancer treatment because there's so many different therapies. And I don't know that I need to have a show of hands of who's had what, but I'm sure there's a diversity in the room. And if you feel the need to share it, you can. But all of them affect potency in some fashion at a different time interval. Some are immediate right up front, some happen a little bit later. And most people with prostate cancer have a little bit even before the treatment gets started. And it's really hard to balance that in terms of everything. So the beginning of our discussion is kind of general. So if you have any specifics, feel free to ask about them a little. So first of all, with erectile dysfunction, I usually make it to clinic about a day or day and a half a week. Most of the other days are in the operating room. And I have guys that come ranging from 20 years old to 90 years old discussing this problem. And erectile dysfunction has two components, and there's actually a good slide I think on here about that. There's a neurogenic function and there's a vasculogenic function. This is a generic slide. This is to show you that everybody's going to deal with it probably at some point. And it's accelerated a lot by prostate cancer therapy. But in general, I think of erectile dysfunction as two groups. One is related to blood flow and one is related to nerves. And both are an important component of sexual function. And they're both compromised by prostate cancer treatments. And sometimes we forget about one or the other. But in general, I would say that the nerves that innervate sexual function, or the arteries that innervate sexual function, are kind of small and brittle. And sometimes they're more sensitive to vascular disease than the coronary arteries to the heart. So sometimes erectile dysfunction precedes all of the consequences of vascular surgery. And it can be a marker of, not necessarily health at times, but is a normal precursor. Also, a nerve communicating your brain to the organ plays a role, and so that has to be there as well. I would say that with time, sometimes with aging, the blood flow is compromised. So a normal erection, this is the picture here, goes from the flaccid state to erect. And what happens is you've got increased blood flow through the arteries. Now, the bodies of the penis, we call it, has an outer layer called the corpora cavernosum. It's a really thick, tough layer. It's super rigid. And the more blood you can jam in here, the tighter that thing will get. And it's not really meant to expand that much. It's really meant to be able to hold its shape in there. So that's what the erection is. It's an increased blood flow to these bodies with very little return outward. And so there's this dynamic between the arteries and the veins that control that function. All under the control of the brain through the nerves. Okay? And that's why there's different treatment options depending on this process. And there are different, it's not an all or nothing thing, because sometimes the blood can come in strong, sometimes it kind of weak coming in, sometimes it leaks out. And so that dynamic is part of the reason why people have problems. But usually it's not an all or none type of scenario. It kind of creeps up on you as that blood flow gets weaker and weaker. So this was just a general slide of erectile dysfunction. It goes to show you here that most of it's vascular. Now, diabetes affects both the blood vessels and the nerves, but I would say predominantly affects the nerves in the other guys. There's some medications that cause it, so a lot of things that affect mood and things can cause erectile dysfunction on its own. And these other boxes are say for prostate cancer and things. I think that box is probably getting bigger over time a little bit. You know, I also do bladder cancer, also affects sexual function a fair amount. And I even do it in females get bladder cancer. For some reason, when it comes to the women, they don't discuss the effects of cancer on sexual function for them. And it's the same with the men as well. I think this one at least has a little bit of notoriety. But one cannot overstate, I think, that the effects that erectile function has on the quality of life. It's not just one box. It can affect your relationship with your spouse. And I think that's probably the hardest one that I see. Sometimes it can affect your own confidence, and that can struggle. And sometimes prostate cancer is coming at a time in life where one is already coming to grips with this sort of change with your own view of yourself and your partner already. So it kind of comes colliding all at one time, and when you add this diagnosis of cancer to it, it can be very difficult. But that just is talking about the overall health for all patients. Now, this is a slide of prostate. This is all we have in terms of the prostate cancer. But what I will say is that the nerves that affect erections and ejaculation are different. Okay? So the nerves that affect erections run along the outside of the prostate. So this is actually a good picture right here. And there's not one nerve. And as a surgeon, I wish I could see it. I can't. It's too brittle. It runs in a whole plexus. So this way this is drawn here, it's got these three little branches. But if you look at the anatomy, if you start doing stains of the prostate, it just runs every which direction. There's even crossover from side to side, but it runs along a bundle down here on the bottom. And it's you can see how close it is to the prostate. And part of the problem is if you pick a treatment modality that misses these nerves, then you're missing the prostate cancer that's right against the nerves. So every treatment option, and I'll sometimes draw these pictures separately, you kind of have to, something you often will have to give. So this is an example of the surgery. So if you do the surgery and you move the prostate, so here's the urethra, here's the bladder, and you're going to sew them back together. If you can spare the nerves, that's wonderful, but you can't really see the nerves. You know, I've actually written chapters for surgeons where I discuss all of the studies that we've done on nerves and all of the maneuvers that we can do to try to spare them. And these nerves are so sensitive to stretch that, or even to cautery. So if I use an electrical source too close to the nerves, it damages them in a way that can be irreversible. And so if you imagine that you're going to have radiation or freezing or pretty much anything that you can do to these nerves right here, then they're going to be compromised. And I think part of there's a lot of advertising sometimes that comes with surgery, but the reality is that the nerves are right up against the prostate capsule. And in a lot of diseases, the nerves are involved by the prostate cancer. And a lot of the other ones are right up against them. And so you kind of have to pick your modality depending on what you want to do. Sometimes you can spare the nerves at the expense of not treating the cancer. Or you treat the cancer and you destroy the nerves all at the same time. So it's a really delicate balance, and it's really hard to be honest up front and manage patient expectations with potency. I feel like we can manage patient expectations pretty well with continence, but potency is so hard to do. So I kind of, sometimes when I give a description of it, if I were to draw a box, and I draw a line right in the middle, that line is the critical site in a man's sort of sexual function where their erections will be adequate for sexual activity or intercourse. And if somebody comes to me with prostate cancer and they have this whole reserve in there still, they have perfect erections to come, whatever their therapy is, they're going to be affected a little bit less until they get to that line. But if you start your consideration of prostate therapy right at that line, you have no reserve, then you're going to be affected. And we do not have a good way of determining where a patient is with that reserve. Because I have a questionnaire, I can give them a score, but not everybody's that honest with me about it. Sometimes if they are honest, they're really not honest with themselves, and so it's kind of really hard to tell where they're at there. So I really feel that every prostate cancer patient is going to deal with this in some fashion, or they probably undertreated their cancer. So this idea of focal therapy for prostate cancer, thinking that the cancer shows up in one spot, a mile away from the nerves, and we treat it in some fashion, we cure the cancer and everything's good, unfortunately does not exist with this cancer. We wish it did. And every time we try to come up with something like that, it never works out. So, yes?
Does something come down the pike where nerves can be replaced or rerouted?
It's a great question, yeah. So nerves don't heal like the rest of the body. So nerve healing is really tough, and it's really slow. So, a lot of people will hear, even if you lose blood pressure to the brain for a short period of time, the brain damage is quick and almost impermanent because it doesn't heal that well. So if I were to stretch a cavernous nerve, so these are called the cavernous nerves, I can see improvement out to 2 years. It takes that long for them to improve. But they really don't regenerate and replace themselves very well. We have tried nerve grafting. We've tried taking nerves from other places and just inserting them in there to see if it will promote healing, and none of it really works very well. I mean, that's still an area of ongoing research. We wish they did, but they just don't. Yeah, maybe a little bit they can superficially heal, but not that great. In fact, I don't know if any of you guys have any scars. I once fell off a bridge and I got like a piece of wood stuck in my wrist. And so when I touch my scar, I don't have good sensation to it, even though that was 20 years ago and my body's healed up. You don't regenerate your nerves in some areas. Yeah.
So you're a robotic surgeon?
I am, yes.
Okay, so since you can't see the nerves, and a patient comes up to you and says, can you save the nerves? You can't, so you really don't know if you're saving the nerves until after the operation.
So I know the anatomic plane the nerves run in. So it's kind of, I'm comfortable with this as a cancer surgeon. For example, if I'm removing a giant mass in the kidney, I don't just want to take out the mass. I want to take out everything around the mass to give myself as much of a buffer as possible. So I'm used to this idea of using surgical planes for cancer treatment. The problem with prostate cancer is, while I'd love to incorporate that model where you take the cancer as wide as you can around it, prostate cancer is unique because, unlike a kidney where I can just take out this organ and there's another one, everything's fine, I have to take out this organ and then put it back together in a way that's going to work and not harm the patient. So I could take out the whole pelvis and cure the cancer and leave you with the mess. Or I could take out very little of the prostate and hook you back up and everything's going to work well, but then I leave the cancer, and so there's this fine line. So the other problem is that the capsule of the prostate, while we talk about it, is not that well developed. It's really called a pseudocapsule. And but I know where the nerves run in the anatomic plane, and so I can find these planes along the prostate where I can come all the way around. The neurovascular bundle, you can't see the nerves, but you can see the vessels. And some people have even described using arteries as a landmark to see them. So, I can get a sense of that, and when I'm in a surgery, based on MRI and all these things that we have now to try to get a sense of what the cancer looks like, I will sometimes intentionally spare part of the nerve, or at least part of the bundle or not. But I think I've read somewhere in a patient forum one time that if your surgeon tells you that you're going to leak urine after surgery, maybe you shouldn't trust him. We've come along far enough away that your confidence should probably be a little bit better. But if he tells you that he can promise you good erections, you should not trust him. And that's why I think patient expectation is important. So up front, I can tell them that I will spare the nerves, but that is a lot different than sparing the function. Because if I stretch them too hard, or if I see during surgery that the tissues are a little sticky and the nerve isn't coming off very well, then I'm going to probably take a little bit more of that nerve bundle. And I can't really predict how close the patient is to this reserve where they're going to have spontaneous erections on their own. So, that's an upfront important decision to have top discussion at the very beginning. And a lot of times, I try to be realistic that very rarely are you ever going to have, your erections will never be stronger, they'll probably always be a little bit weaker. And how weak they are, how functional it's going to be depends where you start. Sometimes I'll spare one nerve and leave the other. And I sometimes will spare the nerves because it affects continence a little bit as well. So yeah, it's a little bit misleading.
So your
Sir.
prostate, the skin around it, you say is not thick enough to take part of it? Leave that in with the nerve that it's attached to?
Yeah, so there's a capsule of the prostate, and it's not a well-defined capsule. There's some layers in there. Some people have described staying inside that capsule when you spare the nerves, and that can do a better nerve spare there. The problem is that all of those patients who are a good candidate for an intracapsular nerve spare didn't need their surgery to begin with. Because, I'd say 20 years ago, 15 years ago, people had Gleason 6 prostate cancer, and we say, ooh, you've got cancer. The C word is scary. And we rush them off into treatment, somehow, radiation or something. And then we all pat ourselves on the back to say that we treated them, and then they leave them kind of with potency, continence problems. And not until a little bit later do we realize they wouldn't have died of their cancer anyway, because that cancer is so slow growing. So we've really changed how we approach prostate cancer, and so you can't, if you're a candidate for an intracapsular nerve spare, you probably didn't need treatment anyway. And nowadays, the cancers that are treated are a lot more aggressive, and it's hard to find cancers these days that are confined to the capsule.
Well, I was diagnosed with cancer, and the nod was in the middle of one side. It was in the middle, and it wasn't on the edge. So is that a possibility to say that? I'm just trying to get an idea of what they might have thought.
Sure. Did you have your treatment done already?
Yeah.
What did you have done?
The whole thing.
Yeah, the whole thing taken out?
Yeah, and a couple of notes.
That's the theory. That's called focal therapy. So if you find a spot that's in the middle, can you just treat that spot and then leave the rest of the prostate? The reality with prostate cancer is that if you do autopsy studies on men in their 80s, I'd say 80% or more will have cancer in the prostate. So most men die with prostate cancer than from it. And the reason that's important is that the genetic problems in prostate cancer accumulate over time, and they end up being multifocal. So even though your cancer is removed and they have a dominant lesion, I'm almost certain that you had cancer in all these other spots. And so it was probably smart to take the cancer out from a cancer's perspective, because when we do the whole mount studies, when we take out a gland and we start studying it, and even start doing gene assays on it to look for the cancer, it starts showing up everywhere. And a lot of precursor cancer cells over here, and so that's why focal therapy isn't working, because it's showing up in multiple spots in the gland. And if you live long enough, your whole gland's going to have it.
Yeah, they took my whole prostate out, but I'm just wondering how they approached it like you said.
It's the hard part about prostate cancer, honestly, is that we don't know what I call staging. Staging is how bad is the cancer up front? You hear on stage 1 through 4. Well, it actually can get a little bit more complicated than that, how we think about it. But the problem is with prostate cancer, we don't have a great way of staging. I mean, this is the only cancer where you have a blood value or an exam that fills a bump. And then you go into a biopsy and you blindly biopsy the organ. Because every other cancer, you have a mass, and then you biopsy the mass. And then you determine whether you have cancer or not. If you have colon cancer, you have colonoscopy, you see a mass and you biopsy it so you know what it is. But on prostate cancer, you get 14 or 12 or 14 cores or 6, or depending on what area you're in. And then you wonder, did I miss it altogether? Did I get it in the middle? Because on an ultrasound, if you see what we think looks like prostate cancer, which is what we call a hypoechoic lesion, it's only cancer 13% of the time. That's not accurate. So it's blind. So here we are. We've got biopsies. We could have missed it. And now we don't have a good way of seeing the cancer. So then we take it, we prescribe treatment, but we can't tell if it's outside the capsule because we can't visualize it. And then, so now you have your surgery, and then you get a surprise that was way worse than you thought, or sometimes it wasn't bad. So the problem, especially in the past, and we're still struggling with it, is we can't stage it. I can't tell you up front with certainty that you've got stage 2 or stage 3 prostate cancer. We just can't do it yet. MRI is helping us, and genetic testing is helping us, but it's still not perfect. So that part's hard. I think that's why it's good to think about how it's going to affect your functional outcomes down the road. So thinking back on erectile function. Now, so prostate cancer, if you have radiation, what radiation does is it kills things. That's its job. So you want it to kill the cancer cells, and it does it by damaging DNA. You know, the reason you put sunscreen on is you don't want the radiation from the sun. So you're taking that same type of radiation that can damage the DNA. We're dose escalating it so much that'll help us. But that causes, scar tissue, and it scars both the nerves and the blood vessels. During surgery, I'll find anomalous arteries that run along the prostate where 13% of men or 10% of men rely on those arteries for blood flow to the penis. It's not coming through the normal canal, which is way away from the prostate, like it should be. So the blood flow is involved with prostate cancer treatments too, and they'll all be effective. Now, this slide deck is really good for prostate cancer treatments because it talks about oral medications and injections and penile implants and vacuum devices and suppositories. And we'll talk about them a little bit, but the reality with prostate cancer is that if eventually the damage is kind of so there that a lot of these don't work anymore. So with nerve spare techniques these days, and when you have radiation, the damage accumulates over time. So in the beginning, you're not going to notice any effect. You'll walk in, depending on what kind of radiation, you won't start seeing the nerve damage or the vascular damage for 3 or 5 years later, or sometimes even later than that. So that one happens right up front, one happens later. But the purpose of these oral medications, for example, everybody sees the commercials on these. We all wish we all looked like people in the commercials. And the reason they work is they increase blood flow. So you take this pill, and because they're increasing your blood flow, they do that by relaxing the arteries. There's some side effects. And you take a pill, it affects your whole body. So that's why you've got some contraindications with drugs. You should discuss it with your provider, but it can lower your blood pressure and things. But in addition to improving blood supply everywhere, it also improves blood supply to the penis. So that's why you can improve your erections. It only works but so much because we can only give the drug but so much. That's why you have a lot of headaches and vision changes with these medications, is because you're reflecting blood flow everywhere. And if you had perfect erections coming in, you didn't need any of these pills or Viagra or anything coming in, and you might feel pretty good if after some sort of treatment, then all you need is Viagra afterwards. But for people that need Viagra going in, that probably won't be enough. And for a lot of these treatments, as there's accumulation of sort of injury over time, it's not going to be enough. So a lot of these treatments that we're discussing are great for the average population that has some blood flow issues, maybe some diabetes, and it's working, but it may not apply to prostate cancer patients because their impotence is really not organic any longer. It's treatment related, so it's going to be a lot harder. So I would say very rarely do these work, only in the beginning stages of some of the therapies. And it's wonderful if it works, but they don't always work, and you're limited by the dose. So all these other treatment options that we have here. Yeah.
Let's say you're taking Viagra and you quit. Do you ever revisit it and have success if maybe you tried it, didn't work? What if you waited, I don't know, years or months or whatever?
Yeah.
If you revisit it, what would be your chances?
It's a good question. I'd say very low, to be honest with you. So the Viagra there's a couple of nuances that you have to take it correctly. So if you take all these medications, you have to take it with appropriate stimulus. You don't just take the pill and magic happens. So you have to have some sort of stimulus. It works best on an empty stomach for some reason. You get better systemic absorption. So that's something that you can do. But the physiology of it is really good. It increases that blood flow pretty well. It's not usually a thing that works today and doesn't work later on. It's usually something that works well in the very beginning, and then over time you start to see that that's not working. And I'll tell you, to be honest, the biggest limitation for me is the cost. It's expensive. The insurance companies don't cover it very well. At least in my population, it's a big sacrifice to do that. And yeah, I give them the biggest dose possible and tell them to cut it in half and use the smallest dose that will work and work their way up. But there is definitely a critical point at which it doesn't work any longer. And you just have to accept that and move on.
Are you going to say that about all those things that work?
Yes, I will. And so, yes, so a person that comes, I'd say diabetes is probably the most common cause because, especially a type 1 diabetic, these are young guys that are affected early. And so they will start with Viagra, and once that doesn't work, they'll move on to these next therapies that we're going to talk about. And when that doesn't work, they move on, and we're going to talk about the penile implants. It's one of the reasons that we're here. But you watch them go through that whole spectrum at a young age because their disease is a lot slower. When it comes to prostate cancer treatment, a lot of it happens a lot more sudden, and so you don't really have that luxury. You can usually try everything at one time, and then you see whether you gave up and you move on to a more aggressive treatment or you don't. And that's oftentimes happens. But some of the radiation patients, it's a little bit slower sometimes. Yeah. All right, so, well, this is up next. This is called a vacuum erection device. This is probably, everything else is pharmacologic, meaning we're using medication to do something. This is mechanical. And I use this after surgery for I call it penile rehab. It's not totally true, but I have this saying that if the penis is like any muscle, if you don't use it, you lose it. And after the surgery, everybody's going to have this period where, number one, they don't feel like having sexual activity, and then of course number two, there's a little while the nerves are kind of at least trying to recover. And a vacuum erection device is part of that. And this is a big clunky machine that goes on the outside of the penis, and you inflate it, and it literally uses suction to pull blood into the penis. The blood flow is the key to prevent scarring. It's the key to try to maintain elasticity. Because you're also, in addition to the other things, one thing that wasn't on the slide, in addition to blood flow problems, in addition to nerve problems, you also have collagen problems with aging, where things aren't as elastic as they used to be. And that elasticity is the hallmark of erections. So you kind of lose that a little bit. But this is, I have some patients that love this because it's a one-time cost. So you don't have to keep buying stuff. But the problem is you get this erection and you have to put a ring on here, and it hurts. And I would say it's a good thing to use for therapy. It's a good thing if it works for you. That's wonderful. I would say that most people find that it hurts. It's really cumbersome. It takes a long time, and it's not all that. It's kind of a buzzkill. It's not all that natural. But some people really like it, and it works for them. I don't know if anyone's ever tried this or not. I actually never tried it, but I even had a patient in the office today who doesn't have a computer or anything, so couldn't watch the CD-ROM. So we put it on in the office so we could watch the CD-ROM and how to use it, and came back and got it later. They say 68 to 80% satisfaction range. That hasn't been my experience, but when it works, it's great for the patients. Now, you have a ring on, so everything's not going to be, may not feel the same. Ejaculation is going to be disrupted with a lot of treatments anyway.
With that suction, and you put the ring around, that stops the blood from leaving.
Yep.
Okay, on a regular erection, what stops the blood from leaving?
So the reason that you see those commercials to call a doctor if your erection's over 4 hours or not,
Yeah.
and I have a lot of crazy stories that I could tell. But the reason that's the case is because it's basically like putting a tourniquet on the penis. So the arterial blood flow is so strong and the veins are so compressed that you've got this big inflow into the penis and nothing can leave. So you're not having blood circulation. And your body physiologically has the ability to turn those arteries on and off. There's a little bit of a spigot. And so that's the mechanism with the venous compression, so that the arteries are so engorged that they're actually compressing the veins, so things are coming in but they can't come out. So you're stimulating that with the device. You're pulling the blood in, and quick before it goes away, you slap the ring on. And that's part of that. That's the problem. Why it can be difficult is trying to get that ring to work. And so then the ring stimulates the obstruction of the venous outflow, and the vacuum stimulates the arterial inflow.
Have you actually ever met anybody that had to call 911 because of the 4-hour curfew?
Oh yes. Not 911.
Well, whatever.
Yeah. No, I had a guy one time that he was an NFL player, and he owned all this stuff in Mexico. And he was messing around with stuff and he shouldn't have been, and mixing it with drugs and things. And so he goes to the airport and asks, takes the first flight he can into Houston, and it says, where's the best hospital? This has been going on now for 3 days. I need somebody to help me. And so for some reason they directed him to Indiana, and I was on call. That's the cancer center. That is not, that is not a trauma center, or not the right place to go. We end up being good friends for a while because of that. Yeah, he mixed, yep, it was. He gave himself an injection here. I'll talk about injection. He didn't need it mixed with Viagra. He had some issues. Yeah. The 4 hours, the reason the 4 hours is important is because, as I mentioned, it's a tourniquet. So when you, as a kidney surgeon, if I've taken the mass off the kidney, I give myself 30 minutes or so to get the mass off and get the clamp off the renal artery before the lack of blood flow starts causing damage internally in the kidney. So 4 hours inside the penis is there, but you're starting to turn healthy tissue into scar. So it doesn't happen all at once, but that happens over time. And after 3 or 4 days, the whole thing is scarred. So not good for that guy.
So you still play football?
As you can see, he probably couldn't. He couldn't get the plays down or something. Okay, this is a urethral suppository. I'm not going to spend a lot of time. I don't like these because they hurt. People stick them in there and they burn and they pee, and I honestly don't even use them just because they just hurt too bad. If anyone's had a good experience, we offer them. But this, for me, the injection therapy is, for me, it's pills, vacuum therapy, injection therapy, and surgery. The thing conceptually, the thing I like about this is that all the drugs that you're taking with a pill that go around your whole body, you can now deliver to the organ. So you can give a higher dose. And so that's why people that don't work with the pills can work with this. Now, it takes a lot to get a guy over a fear of needles for some reason. And it's a small insulin needle, and it takes practice, but it's a really good tool it's actually fairly natural. You can dose it how you want it, you can control the erections. It's good as long as the mechanism and the blood flow is still intact. It's a good thing to go. But eventually that won't work either. And so I think that the reality is for prostate cancer patients, we go through all of those. And when they don't work, this is the next big jump. This is always going to work as long as the device stays in place. But this is the last resort. Because in all of the other ones, there's no disruption to the normal anatomy. The penile implant is the device that we're putting in that can help you. And there's actually kind of a cool movie that works here.
It took a minute or two for it to come out.
I was wondering if I could make it larger. But I don't think I can make it larger. But this is put out by, I guess, AMS, now Boston Scientific. I actually show this to my patients because it's kind of a cool little video. But there's a pump that hides in the scrotum, and there's a reservoir that's stuck somewhere in the body. And when you push this pump, this fluid goes from the reservoir into the shaft of the penis that you've now replaced with this device. Okay, so that shaft can never be rebuilt. So this is a permanent thing. And when you're done, you push the button, and it goes away. That's kind of our last resort for people that have erectile dysfunction. Now, the device itself is pretty awesome. I have patients that had it when they were 60, when they're 90, and the device doesn't work anymore. It lasts for 30 years, which is great, and they want it back. It's a little uncomfortable sometimes at that age, but that sometimes people really like it. But it's kind of a big thing. So I don't know, do you guys have any questions about that right now?
Do you have anything with it also, or is it just a?
Yeah. It depends on your situation. So if you've had a prostatectomy, or if the radiation has scarred the prostate, but the seminal vesicles aren't involved. For prostate cancer patients, the ejaculate's probably often dry, but the orgasm should still be there. So this should not affect that at all. The nice thing about it, and actually, Dawn has this cool thing. I can even pass it around. But this has one cylinder. There's two erectile bodies that I showed you in there. And so usually you have two. This is an example of the pump. And they have all kinds of devices now that, like this one expands a little bit as you pump it up. And then you push the button here. If you guys want, I can just pass it around and carry plug up the thumb. I would say that I'd say the pros to this is that when somebody has used up all of the other devices, this will work for them. And it's good. And for somebody that sexual activity is really important to them, everybody will elect for this. It's a little bit scary because it's surgery, and surgery is scary, and so you're going to go through, you have to put your confidence in somebody else for a little bit, and you have to heal from it. Prosthetic surgery involves risk of infection, and there's been a lot of technological advances. They're now coated with layers of antibiotics, and I'd say our infection rate is probably less than 1% for normal people, and even for diabetics that have higher risks of wound infection, less than 2.5% to 3% or so. So most people do really well, but if you have a problem, sometimes you have to go through more procedures to get it done. There's some people that don't work on it, so sometimes, like for that 90-year-old, for example, that really wanted it back in, his arthritis had gotten so bad he couldn't even use the pump anymore. So it's not perfect for everybody, and so those are some logistical issues that you want to work on. Talk about. But I've had some men that are young and actually have neurologic disease that are pretty bad, like some Parkinson's and things, and their partner is willing. It's important for the partner, so that's something that can do. But I'd say the patients, when they get it, it always works. Directions there when they need it. It's going to be adequate for what they use it for, and they're very happy with it. Prostate cancer is hard post-prostatectomy because a lot of the reasons that people go into prostate cancer treatment sometimes is the goal to avoid surgery. That's kind of one of the tenets of their treatment sometimes. And so then taking this step is sometimes hard for them to get over it, and can be some scarring from some of those processes. But the surgery itself is pretty easy. You can't use the device for about 6 weeks, because then we activate it 6 weeks, and then after that you can use it. And so patients are really happy, actually really happy with it. Yeah.
How many have you installed?
I don't even keep track anymore. So in residency, I worked at the VA, and the VA was interesting. We paid, the VA covered the prosthetics. And surprisingly, working at Franciscan, I am totally insurance blind. I just take care of whoever comes through my door, and the institution determines all that. So I don't even, but actually Dawn has helped me realize that insurances will cover this for patients. Sometimes it's cheaper. Yeah, so some people, that's cheaper than the Viagra in some situations over the long term.
In the long term.
But in residency, we go at the VA, we do 6 a day, and we do that every week or every other week. So we've done a lot of them. As a cancer surgeon, I do a lot of the cancer surgeries, and I do a lot of the revisions. I do these, and I probably only had to do it on a handful of my patients so far here, because I'm hoping that they'll do well enough with the surgery. But I've probably done a lot more on organic evidence here so far than some of the prostate cancer patients. But we do a lot of them.
How does it affect later on, like hiking, biking, tennis, your exercise? How's it?
Oh, great. That's a great question. Do we have some people here that,
Lonnie.
yeah. Would you guys feel comfortable commenting on that?
No, I was talk.
Yeah, in fact, I could turn the time over to you guys if you want to talk about it for a little bit.
Ready?
Sure.
Glad to.
Well, he's coming up. What are the downsides?
Of the device?
Yeah.
Well, so there's a lot of different kinds of devices. And I think the answer to your question, they even make one that's a malleable prosthetic that never goes away. You just bend it down. Those kind of hurt. There's constant pressure. The downside of this device in reality is if you don't know how to use it, or if you have a complication where it gets infected, and it can erode. That's pretty rare. So that's if you have a problem with it, such as that, that's a downside.
And I think the other thing is a mechanical device, so, I mean, they don't last forever. It's like a car, you have to get it tuned up or fixed after a certain amount of time. So these generally last 8 to 13 years is how literature supported it, and you can go in and get it changed out, and just going to take it out and put a new one in.
Is that a big deal, changing it out? And I'm
No, not
thinking
really.
in 8 to 13 years is gonna be new technology.
You'd think, the device has been so good, it hasn't, outside of really the covering of the device, this layer on it, and there's some nuances to how it might expand. We haven't had a ton of developments in this area because people have been really pretty happy with it. It's all relative. As a cancer surgeon, I'll do an all-day surgery. To this, that takes 90 minutes to put in, to me it's pretty minor. It's in changing it out and putting a new one. The surgery itself is technically easy, but you're going to have some pain afterwards from it, and that's the hardest part for the patient.
Are there any airport security issues with the device?
No. Good question.
If you have an MRI, there's one little dot that shows up on an MRI, and they say, "What you got there?" You say, "No, I got an implant."
All right.
So I run across that. But well, my story, I didn't come here like you guys all at once. I was more of a gradual. I started having problems with erections, worked sometimes, most of the time, but not, they started failing. By the time I hit 60, it was very iffy. So then I went to Levitra and Cialis in that stage. The only thing I got out of those was a horrible headache and great disappointment. Where you have to take the pill an hour before you have sex. You plan, you take the pill, you get all ready to go, and then it doesn't function. And then, it's bad enough when you don't function anyway, but when you've made all this effort and set the stage, and then it doesn't function, I think both your partner and yourself, great disappointment. So I struggled through the pills. Like I said, went through Cialis, went through Levitra, and then I just kind of didn't do anything for a little while. And then when I was, I think I was 67, 68, somewhere in there, I had enlarged prostate. So I went for treatment, and I had the TURP, the transurethral prostate resection, where they go in and rotor-root it inside out so that you can work. And at that time, I talked to my doctor about my impotency problem. And so we discussed the injections. So after I got healed from the surgery, then I started on the injections. And there again, they're very expensive, very expensive. And you start out at a low dose and you got to increase it. And once again, the failure is so devastating. You go and get that injection and expect it to work, and then it doesn't work, and you can't inject again for 24 hours, so then you increase the dosage. And I went through the process where I went to the highest dosage that they said they could give me, and then I just had catastrophic pain. Didn't have an erection, but I had such horrible pain. And they give you, there's an antidote that's supposed to work, and that doesn't work like it's supposed to. So ice bags and stuff. And I was in bad shape for a little while, but it got rid of that. So then I went back to my doc, and I'd been researching the implants, and I chose for the 3-piece implant, which is what's passed around. Like the doc said, you've got a malleable that stays in, and then there's a 2-piece. I'm not sure exactly how that works. And the 3-piece is the most, I think, the most efficient. It worked well. The surgery, as you can see, I'm not totally intact here. I've had 35 surgeries in my lifetime, and the surgery for the implantation was one of the least painful, easiest surgeries I had. They go through the scrotum, and so you're not don't have any abdomen issues, and bandage you up. And the worst part about it, well, for me, all the surgery I had, I got to where I had an aversion to ice therapy. I just hated it. And so when the doc said put ice bags on it, I didn't, and I regretted it. So I had a swelling issue that then I put ice on it. So, I suggest you follow the doc's instructions. But then again, you got to wait 6 weeks, and you're all ready to use it because 6 weeks is a long time to wait. I mean, you're feeling healthy and everything's healed up, and you got to leave it alone for 6 weeks. But then, it works great. It's easy to inflate. It stays inflated until you're ready to get rid of it. So, where before your time with your partner was limited by your ability, now that's no longer the case. It's till you're too tired, I guess. It works until you're ready to undo it. And unlike the 4-hour thing, you don't have any restriction. There's nothing, no problem. No health issues in leaving it inflated. He's asking for, with exercise and stuff. I do notice the bulb is put up in your lower abdomen, and when I'm doing strenuous work, it can auto-inflate because you're pushing on that, and so it'll fill to some degree. It's not a problem. It's not like you're embarrassed walking around a room or not. I mean, you notice what you've got in it, and when it gets to a point, you just want some of it out. But I have no problems with it. It works very well for me. It seems to be a natural feeling. You function, you have all the sensation that you would normally have, and I think it's a great product. And my wife is here if you have any questions that for her as well. But she doesn't complain about me either, so I guess it feels adequate in that regard. So
you're both happy customers?
We're both happy customers.
Okay, how long have you been using it then?
I'm going on 2 years.
Okay. And your wife, you're a happy customer?
Yes, I am.
Okay.
But like I said, it's a relatively easy surgery. I mean, I haven't had the prostate cancer, so I haven't had that surgery. But the transurethral, I thought that was probably a little more painful than the implant was.
How did you find a competent doctor that's done enough procedures that you were comfortable having him do it? Him or her?
Well, I just kind of stumbled on my doc, I guess. And he's part of the group. I don't know, are you in the group that there's 5 or 6 docs at
Who did your surgery?
Haberman?
He's in multi-care.
Oh, okay, you're Franciscan. Okay, there's a group, like I say, there are 5 or 6 of them, and different ones come to the different presentations we've had. He was in Auburn where I was when I was looking for a urologist, and when I got interested, then I just started asking questions. And he had the answers, he did it, and I just felt comfortable.
Any irritation or complications with urination?
No, not at all. Not at all.
So normal urination after the surgery?
Yes, it doesn't affect the urethra at all. The urinary tract is not involved in this surgery. They run the tubes up to 2 vessels that they show. And in fact, if you have any normal erection possibility at all, you can still have some residual, natural type of erection around it. I mean, it doesn't destroy, it just, once it's in, you can't remove it, have any kind of, yes.
Ejaculation now, does that still operate for you?
Well, I have orgasm. When I had the prostate surgery that I had, I no longer ejaculated. So that didn't, there was no, you know.
What about the large part of the sensation is in the ejaculation, from my experience? You lose a lot of sensation when you lose ejaculation?
No, I haven't. I have the same,
That's actually not true. The ejaculation is associated with orgasm, so there's that mental component. But the actual emission of fluid is not what causes the orgasm. It's the propulsion it's the actual motion of the body propelling the semen.
That is not what I experienced.
So if you look, we do a lot of surgery, big cancer surgeries where we involve the nerves up in the chest behind the great vessels. And so we'll do surgeries where young guys will have a loss of ejaculation. Only 13 to 15% report that it affects their overall orgasm. So there is a population of patients that have that association. So it's not to say that it doesn't happen.
but if you're ejaculating before you have it, you will still ejaculate. It doesn't affect the ability to ejaculate.
Well, I found that the ejaculation, as I got older, was anything that was sensation. And once the ejaculation quit, the sensations almost left. What was going on there?
So that you noticed when you have a dry ejaculate, there's a difference in how it felt?
Well, the part of the sensation was the ejaculation,
Yeah.
what I'm saying.
Well, so he actually, after the TURP, his ejaculate's not dry, it's just retrograde. So his semen, instead of coming out, goes in the bladder. And so the direction of flow is changed, but the body is still trying to propel it. So in that situation, the orgasm is the same, even though the semen is coming.
The sensation isn't the same.
Well, so and that might be in the 13 to 15% who report that their orgasm is different. But for most people, it's not the actual emission of fluid. It's the body's mechanism of trying to propel the fluid that causes that euphoria, that sensation, that orgasm. So a lot of times when people lose that don't ejaculate, they also don't have the orgasmic experience. But if you have the same feelings but no fluid comes out and it's not as pleasurable, then that might be in the 13 to 15%.
The sensation is the blood leaving, isn't it?
No, of orgasm.
Yeah.
No, it's a bulbospongiosa reflex. There's a reflex where your body contracts to try to propel the semen out. And the refractory period where you lose the erection is individual. Some people that's immediate, but some people it isn't. It's not the blood leaving, it is the actual contraction of those muscles that's associated with the nerve sensation that causes that pleasure.
And I still have that contraction sensation, they're just
Yeah,
not
that must
pushing
be
anything
a
else.
special case.
So if you have,
Because it was really, in my opinion, what you put up with, what was
Well, part of the problem is with the erectile dysfunction. When the erection isn't hard enough, you don't get that, you don't reach that climax. So sometimes it's multifactorial.
It was the pump in there. What I'm saying is that it's one thing to when the ejaculation, after the flow of semen through the penis, a lot of the sensation, most of the sensation left. It wasn't the great excitement that sex is supposed to be. So that's just one experience.
I have a question for the doctor, without impugning myself or anyone else in the room. Let's say you have a normally active single male, female, who has had prostate cancer and has a implant, and he's sexually active. How should he protect himself from HIV?
Well, honestly, this implant is mostly hidden. So you'll have a little pump in the scrotum. Everything should be the same after that.
But if he's having, shall we say, indiscriminate sex with whomever, should he wear a condom?
Oh, yes.
You also are blessed with incontinence. You need to get the artificial sphincter installed on the other side.
You can. I will say, fortunately, the artificial urinary sphincter is a device that ANS can also make that, well, so here, I put this picture up so you guys can see. This is the urethra. This device, these cylinders, they go in the erectile body, but should be separate from the urethra. Okay, so if you have to have an artificial sphincter put in, it's encircled in the urethra. Now, I'll tell you, I do have some problems with that device. See, unlike the reason that the penile prosthesis is good is that when it's deflated, there's no pressure to the tissue, and so that's why it's so much better, I think, than some of the other devices that have, the malleable, for example, it's constant pressure. Eventually, it's going to erode out. With artificial sphincter, it's working by creating pressure on this tissue, and eventually will lead to some problems at some point. I think that for people that there's other options like a male sling that is not a device that's putting constant pressure in here. That are other options. So there's other things that can be done, and you can do it. I think that the biggest distraction of quality of life is urinary leakage. I think that's probably the worst thing that can happen because you're constantly in fear. It prevents you from doing things you want to do, and so we'd certainly use that in people that need it. But hope that nowadays we've gotten a lot better that we don't need those devices very often. But you could carry both. You would have, when I've done them both before, I'll put one in one side of the scrotum, one on the other.
Wow. With the sling, you could see I've done at the same time. You have
Yep, yep, you sure can.
Is he saying, I'm not sure what he's saying, but is he saying like at climax sometimes you have urine leakage at climax if you were incontinent?
He wasn't, I don't know if that's what you're saying, I think that some people with prostate cancer will have both urinary leakage and impotency. And so that would be a problem if you have a device that allows you to have sexual function, but then you leak, especially in the, during intercourse. That would be a problem. But I think his question was a general: can you do them both at the same time if you have that problem?
Does normally when you have an erection, you can't urinate because there's so much pressure, I think, on the urethra. Is it the same thing with an implant?
I would say that's not normal. I would say that happens to men, but I wouldn't say that that's a normal thing.
That you would or would not do?
That you would not be able to not urinate.
Oh.
Yeah, so I would say that some people have reported that. But in fact, actually, a lot of people will use urination as a way to sort of get rid of their erections at times. So they should be totally functionally separate. Now, I will say that people that have erections, that have large prostates at the same time, or something that's causing obstruction of the urinary flow, again, this goes back to that reserve. So if they have a weak stream already, and there's something that might be causing an obstruction, then an erection of any kind of pressure on the urethra might sort of delay that. That is, urinary retention with a penile prosthesis has really never been a problem. Because you can push the button and it goes away as soon as you want it done. You can put it right back whenever you want it. I'd be interested to hear also we have two people that have had experience. Thank you for sharing. I appreciate that. That was great.